dermatological sojourn. For us pediatricians, it is rather easy to diagnose some rashes along this journey, like the erythema toxicum, which is seen in the newborn period, to the infective measles rash, which is seen at childhood, or till in the adolescent, where we get the usual acne. That's the last bit of the journey. But sometimes we do stumble on this journey, like if we see a sudden psoriasis or pemphigus, or don't forget the deadly Steven Johnson's. Is it Steven Johnson's? Is it TEN? So today, to help us, we have a seasoned dermatologist to help us on this difficult path of the sojourn. I welcome today's speaker, Dr. Ashok N, who is the head of the Department of Dermatology and Venereology in the Government Medical College, Thrissur. Hearty welcome to you, sir. I also welcome our Dr. Anandakeshwan, additional professor at the Government Medical College, who is the chairman of the Mother and Baby Friendly MBFHI committee. Can you see an extra glow on sir's face today? He is very, very happy because today, for the first time in the Kerala state, one hospital from government sector and one from the private sector has been accredited with the MBFHI status. So congratulations, Dr. Anandakeshwan. Your hard work is really showing rewards, and welcome to today's program.
Thank you, madam.
Our last discussion was on drugs and bugs in the PIC for the Thrissur talk series by Dr. Baswaraj, our Honorary Secretary General. It was very well attended with more than 100 attendees. Our next topic coming next Thursday will be by a past National IAP President, Dr. Digant Shastri. This month, October 23rd and 29th, we have the NRP program for the registered participants. This program is a collaboration by IAP and the NNF. Well, friends, soon the central IAP elections will be announced. Do not forget to exercise your franchise in the true IAPian spirit. Another program we are having is a one-day workshop, which is based on the NTEP, National Tuberculosis Eradication Program. And hey, this time it's going to be physical and you all have to attend it. Also coming up is the Kerala State Pedicon, the Golden Jubilee, from December 1st to 5th. I hope many of you all have registered. Well then, with these announcements, I sign off and over to Dr. Anandakeshwan to moderate today's session.
Oh, any seniors to Parvati, madam? Say 2 words, madam. Madam knows Ashok very well also.
Oh, good evening to all. എനിക്ക് ഡെർമറ്റോളജി ആയിട്ട് വലിയ ബന്ധമാണ്. എന്താന്ന് വെച്ചാൽ എൻ്റെ നാത്തൂനാര് ഡോക്ടർ ശ്രീദേവി ഡെർമറ്റോളജിയിലാണല്ലോ. അപ്പൊ രണ്ട് അശോകൻ സാറ്, സീനിയർ അശോകനും ജൂനിയർ അശോകനും രണ്ടുപേരും നല്ലോണം അറിയും. പിന്നെ ശ്രീദേവിയുടെ ഒപ്പം തന്നെ വേറൊരു ദേവിയും കൂടെ ഉണ്ട്, ദേവി. അപ്പൊ അവിടെയൊക്കെ എല്ലാം ഡ്യൂപ്ലിക്കേറ്റ് രണ്ടുപേരാണ്, എല്ലാം ഡബിൾ ട്വിൻസ് ആണെന്ന് പറയാം അല്ലെ. എല്ലാവർക്കും ട്വിൻ നെയിംസ്. അപ്പോ നമുക്ക് നന്നായിട്ട് ഡെർമറ്റോളജിയെ പറ്റി കേൾക്കാനായിട്ട് അശോകന്റെ ടോക്ക് ഞാൻ നേരത്തെ കേട്ടിട്ടുണ്ട്, എന്നാലും നന്നായിട്ട് പറയാൻ അറിയാവുന്ന ഒരാളാണ്. ഓൾ ദ ബെസ്റ്റ് ഫോർ ദ പ്രോഗ്രാം.
So, very good evening, respected President Dr. Reddy Shantakumar, Secretary Dr. Srijit, past State President Dr. V.K. Parvati Madam, senior members Dr. Ravindra Verma, Dr. Saroja Madam, other dear friends. I think it's a very good day as such concern with me. First one is that, as Reddy rightly mentioned, today 2 hospitals, one from private sector and second from government sector, declared as MBFHI. Second one is my close friend, Dr. Ashokan, head of the Department of Dermatology, is giving a talk. As you know, we starting from AIA, so we are in MBBS standard. We are together, very close, keeping very close friendship. And today's talk regarding the common skin problems in children. As we know, skin is the largest organ of the body. We പഠിക്കുന്നതാണ് largest organ of the body. And also, what concern with us is that we are seeing around 10 to 20% of the skin disorder in our daily practice. As such, we got very good training under Sugudan sir and other madam, Najeva madam, and others during our MBBS days. I think to an extent, I think we are expert in managing many, 70% of common skin problem or identifying them. Even though we cannot read them, we can identify them because we are seeing so many conditions. I think to an extent, I think 2 MBBS subject which is very useful to us is, at least for me, is one is dermatology, second is psychiatry. During this COVID season, we are seeing so many psychiatric illnesses which we can cure ourselves. Second thing is that the dermatological problem. And also, unlike an adult, I don't know, Ashok may be angry with me, all skin condition to an extent, it is a simple and acute and it may be very curable, unlike an adult. Even though we are seeing sometimes we are seeing psoriasis and something like that. Otherwise, all the pyoderma, all the infection, and very curable. The most important thing is that even though we got last day also, Langerhans and histiocytosis, SLE, HS, all the systemic disease will manifest with some skin problems. So identification of all these is very, very important. So as we know, skin got so many functions of the body. The barrier, cellular, structural, chemical barrier of the body. But what is now new? What is SALT and other immune system, skin associated lymphatic tissue, and the body protective mechanism? There are so many other inflammatory cells, cytokines, mast cells, Langerhans. So many cells. I think it is as such the immunological property of the skin is as such developing. So to talk about all these things, common problems and everything, we can expert speak. I already mentioned my classmate Dr. Ashwagan. He completed his MBBS from the Kozhikode Medical College with me, then MD from Trivandrum, and he is now the head of the Department of Dermatology, Thrissur, and he got more than 28 years of teaching experience. He got more than 60 publications in various international journals. And he was associate editor of a Skin and IDVL journal. He was past president of IADVL Kerala chapter. He got many oration awards. I think he got 3 orations prestigious. One is a Professor BKH Nair Oration Award, IADVL Kerala oration, and also he got IADVL Kaniksa oration. He got 3 important oration award. And he also now presently the ethical committee chairman of Thrissur Medical College. And he's very much interested in research and also teaching also. He's a very favorite teacher. I think now after he took charge as the head of the department, all the regular awards for PG students, state and national level, Thrissur is getting all the PG and PG awards at state level, national level for various presentation, paper publication, everything. Now Thrissur Dermatology department is in the map of Indian dermatology, academic level all over India. So with this few introduction, I invited Dr. Ashwagan to deliver his talk. Over to Dr. Ashwagan.
Thank you, Dr. Andreasen. I was wondering, are you talking about me or someone else? Anyway, thank you for your very nice, kind words. Shall I start sharing?
Yeah.
By that time, I think I will. Please wait. I think I am not able to see that presentation right now. Please wait. I will.
So audience can type their questions in the chat box. We got very good number of audience today, even though there are 3-4 meetings simultaneously. We got very good audience. So message cheyya. The technical problem
normally I minimize the desktop. I search ചെയ്തത്. Okay, it will come, no problem. കുറച്ച് too many files ആയിപ്പോയി ഡെസ്ക്ടോപ്പിൽ, അതാണ്. I think it will come now. Are you able to see it now?
Yeah.
I will start from the beginning. Is it okay? I think it should come now, isn't it?
Yeah. Side view.
Okay now, isn't it?
Yeah.
Okay. So thank you once again, and thank you IAP organizers for having me here with you. It is a very pleasurable experience to be with you, even though it is not a physical meeting. And particularly thank Dr. Reddy Shantakumar and Dr. Sid Kumar, who are the organizers of this program, along with my own friend Dr. Andakeshwan, and all the senior colleagues here, Parvati Madam, for her very kind words about me. So actually, when Andakeshwan asked me to present a topic, it was actually only 4 days back. So I was initially, when he tells something, it's very difficult for me to refuse. So what happened? I first agreed. Then only I started thinking, what can I talk in such a short period of time? So then I asked him, can I present some cases and do a case-based discussion rather than a specific topic? Because when we present a specific topic, I think we should prepare for it for some more time. So these are all cases which I had seen over a period of years. Actually, many of these photographs are of a few years back, actually, because at that time I used to take photographs very often. Nowadays, I see a lot of cases even now. Somehow those habit of, I think the mobile phone has created problem actually. Earlier, I used to carry a camera, and so it used to be very seriously being done. So that issue is there. And regarding Dr. Andakeshwan's introduction, there is a small correction for me, which I would like to make. My MD was also from Calicut, under Sudan sir and Lakshmi madam. So with that, basically what we propose to do in the next 30-45 minutes, which Dr. Srijit told is the usual time frame in which we have to do, is a picture-based questions and quiz. So no specific topic. So it will be all on very common conditions. So I ask for pardon to many of the very well-known senior colleagues here. So they may be able to pick them up in a jiffy, and so they may. I am requesting them that they should not feel that their time is not utilized sufficiently because the cases are too simple. But I thought not to communicate to everyone. The common things are common. That is our process. What they tell. Common things are common. So let us discuss something about them. And my focus will be only on clinical diagnosis. I won't go into any how to work up or treatment or any other things in this session. And I have a request that please don't save or copy these photographs, because they're all clinical photographs. They have copyright, and they may need consent also of many of them. So please don't do that. That's my humble request to all of you. And the discussion will go along in 2 ways. There will be 2 types of questions are there in this entire session. One will be a quiz, which I hope I will be able to do. I learned how to do that under the instruction of Dr. Srijit only today evening. Hope it will work out. And for that, after I give out the question and the options, ABCD options will be there, so you can choose them, and you can participate in that online quiz. Let us see how does it proceed. If it takes a lot of time, maybe we'll have to go back to that only MCQ and chat box type of answering. So there are some questions, 10 quiz questions are there, and a few other MCQ questions. And anytime if you feel that enough is enough, please indicate to me somehow that then I can stop, because there is no question that it has to be finished entirely. So anytime we can stop. The purpose of this session is is a learning. So even though this is a quiz, don't take it in a competitive spirit. And I am actually not offering any prizes either. This format, I thought that I will choose because I thought it will stimulate your gray cells and keep you active rather than being very passive. And usually and always the visual images are always better than telling a lot of things. And some of them are quite simple. I'm sure you will be able to answer very easily. Some can be little confusing, but please don't bother. And please don't complain to me that all necessary clues to diagnose that we need more clues. That is true actually to some of them. They may need little more clues, but I put it purposefully because I want to take this discussion alone. Only for that purpose only this quiz is there. It's not for like a competitive quiz or anything. But please participate as far as possible actively. And all options are in an alphabetic order, so there won't be any other pattern. So please don't think about A, B, C, D or anything. And feel free and relaxed. We'll enjoy this quiz in a non-competitive spirit. That is my theme for today. So we'll start. So I will tell only very few things. You can look at the picture very closely. And I may give some clues after this. After that, you can, we will try to go for the online quiz. I hope I will be able to do it. Okay. So these are the clues. Actually, I can give more, but no, I am limiting. I planned that I will tell only this much. Of course, there are erosions, which already you must have identified. You don't need me to tell that, no? Silly. They are erosions and they are of 2 days duration. That means a very short duration. It's only first episode.
Okay. Many people answered impetigo.
Okay. Impetigo. Okay. So maybe we'll go to the. So we'll continue with this without going for the online poll. It's not mandatory. So atopic, our options are atopic dermatitis, fixed drug eruption, herpes simplex, and impetigo contagious. I request you, please don't answer before. Because all the quiz questions, please don't answer in the chat box, so that we can discuss something. Because I am sure many of you will be able to answer easily. But what I want to address the other group also. So please give them also a chance to give their answers. So this is herpes. So herpes usually presents on the, it can be the recurrent herpes presents on the mucocutaneous junction. First thing, it is not that common like in adults and children that I think I should be able to tell. So usually typically on the mucocutaneous junctions, and they are actually grouped vesicles which can also become eroded. So sometimes there can be a confusion for some people. It is possible. First episode can also be limited lesions in some patients. Herpes, even though it's because sometimes a secondary recurrent can come for the first day without a pre-identified primary stage. And atopic dermatitis, as you know, will in the infantile phase, that is a time when you get a lot of facial involvement. You find the lesions on the cheeks. So why does it occur on the cheeks? Can anyone answer that question? I think I'll go one step further, considering you have already answered very quickly. So why these cheeks are preferred in infants, and particularly in infants? Anybody would like to offer? You can either answer with in the unmuted answer or in the chat box. Okay, it's actually because, as you know, atopic dermatitis, the main thing is that they have a very, irresistible urge to scratch and itch. So in infants, that young age, that is the time when they are mostly lying down and they will be rubbing the face on the cheeks on the mattresses. So that is supposed to be the reason. And this is the other option, the fixed drug eruption. which can occur anywhere. It can be on the mucosa, can be on the skin, or it can be on the mucocutaneous. Mucocutaneous junctions are very common. And how do you differentiate? Again, may not be very common in children, but the one, if recurrent history of the same site is there, it can help. But remember, it can come for the first time. That is also possible. But usually you will be able to identify that unmistakable pigmentation. May not be very evident in very early case, but even then, that some amount of pigmentation in acute cases will be giving you a clue. So, because it is COVID time, and we are most of us are not getting much chance to travel and see places as we used to do earlier. So I have added some of the pictures also to indicate the interval between one case and the other, so that we can try to enjoy some of these pictures which we would normally have loved to go there and view them. So I'll go to the next case. So this is a picture. I'll give you a clue. Again, short duration, expanding borders. I'll give you one more view to that. Short duration, expanding borders. So we'll take it as an MCQ. That's no online use here. So our MCQ is, so you can try to answer in the chat box. So MCQs in chat box and online use. So any options? I have not seen anything so far. Okay, okay. Shall I move forward? Okay. SCAR also is a possibility. Actually, okay, my choice is also custody impetigo. Actually, this patient had custody impetigo because I know the patient's details also, which you don't have that advantage. So when we keep us spotters, take it like in the learning perspective only. This is not to challenge anyone's diagnosis or anything, because when we actually examine, we'll get history and many other things to make a diagnosis. So actually, what could be the difference between a crusted impetigo? Because there is a crust, the SCAR also there is a crusted. But actually, the difference is that in SCAR it will be a full depth skin involvement. Not only whereas a crusted impetigo, the crust will be more superficial only. So it is mainly an epidermal lesion only with minimal dermal involvement only. Whereas SCAR will be entire the skin, including the deep dermis, will be affected. Will be a more deeper one, so maybe more adherent. And gangrene, obviously, I don't think I have to discuss. And psoriasis is a papillosquamous disease, and if you examine carefully, you can rule it out. And this particular lesion, I think I don't have to teach you, because this is your domain. So this cigarette burn like a scar of the which condition? Scrub typhus. And also the scrub typhus, usually the lesions will be more in the covered areas, unlike our patient who had lesions on the hand. Even though the site is not a 100% reliable differentiating point, but relatively it is more commonly found. So we missed this last year, we missed this year also almost. Let us hope we will be able to get it next day. So this is my third case. So picture. Same patient. A brief history, again short duration, rapid progress, and toxic. So we will go for MCQ here also. Option A, Pemphigus, B, SSS. I think I am getting the answers. Okay, no doubt here. I think everybody is answering. I'm sure you might have seen so many patients with this presentation. And I will just show this interesting photograph that this younger brother got this from this elder sister from the pyoderma lesion on the face. And younger children tend to develop the this toxic effect more markedly, staphylococcal scalded skin syndrome. And pemphigus, not so common in children. Again, it is a little more common in the middle-aged individuals, older individuals, but usually tends to have a more chronic course. And sometimes, if it is very severe, patient can be sick, but it won't be so acutely toxic like in a staphylococcal scalded skin syndrome. And you find marked mucosal involvement in most cases. We can differentiate. The 10, which is another differentiating condition. Again, more common in adults. 10 can occur in children also, but more common in adults. And it can be a little difficult. So you may even need a biopsy to differentiate sometimes, but the charring of the lesion is the differentiating point, and the skin going off in sheets. Whereas you find the flaccid bullae in the staphylococcal scarlet skin syndrome. The drug history, we can tell it is useful, but practically it can very often be confusing because most people would have taken some drug during the course. So whether it is that drug or may not always help actually, even though you can write in the theory answer book. Practically, there can still be confusion. A toxic shock syndrome, you don't get such a flaccid blisters that commonly. You find more the mucosal erythema, lips, the tongue, which can even appear as a strawberry tongue, and the palms and soles can be very much erythematous. And the skin lesions are most commonly maculopapular rash, even though the patient also can be toxic in TSS also. So it is obvious, no? Kalamandalam. We'll go to the next case. Very simple, no? Send it. I think I not even give you options here. So we'll go for a quiz. Let us see whether it is working. Are you able to answer now? Are you able to answer? Okay. I think I am getting answers. I'll wait for maybe 5-10 minutes. Okay, I think this is quiz 1 answer has come. Okay, so that will end. I think we have to go for, we didn't take that quiz, no, send it. So we'll go for the quiz 2. Okay, quiz 2 we will launch. Sorry for that wrong set because we didn't do that. Okay, I'm happy. We'll enroll. Okay. That tinea was very simple, tinea pruris. But sometimes why I showed that picture is to give you, bring out this point that nowadays the tinea has become much more of a difficult disease to manage. Very often you get very extensive lesions who don't respond well to therapy as it used to respond. Whether it is an antimicrobial resistance or some other changes have come in the species profile. So all these are actually under investigation. So you find such, and many of us think that indiscriminate use of steroids has a role to play in that. And this patient probably must have applied some steroid also. So you are not finding so much of inflammation, but still that border is there, which can help us to differentiate. But sometimes even that border may not be very much apparent if they applied steroid. So now, what is this? Can you answer in the chat box? What will be your diagnosis? Chat box, please. Any answers? Okay. This is the first time I think you are making me satisfied in my presentation. You can think about tinea here also, because it's a common site, and you can find the well-defined borders. But what now tells you that is something more is that it is a uniform type of a plaque, rather than there's no significant peripheral activity. Are you able to appreciate it? It's almost uniformly elevated. And you are finding a lot of involvement of the scrotum and the pineal skin as well, not limited to that. Even though sometimes you may find, rarely you may find tinea. This is not. And again, I am not expecting that you will make that differentiation only by the photograph. But this patient had flexural psoriasis. So it may very closely resemble a tinea purus. So that's why I'm telling why I am presenting this is not to what you say, challenge you, or not to check whether you are able to answer, nothing like that. Just to demonstrate to you that it can be confused with tinea very often. And whenever we find any lesion on the groins like this, many of us are tended to think first about tinea only, which is right also. But this is a flexural psoriasis. So patient had lesions elsewhere. And flexural areas also, you can get other type of lesion also. This you can go also intertrigo and actually candidiasis, because intertrigo candidiasis, because candidiasis can be one cause of intertrigo, not all the time. And you may find this type of whitish color, etc., erosions and satellite pustular lesions are all features of candidiasis. So we'll go to the next case now. Again, another annular lesion on the waistline. You can find that well-defined annular lesion, and you can find some scaling more and little more thickened in the periphery, isn't it, compared to the center? So you can even call it as a peripheral activity. So this is, I will give you, before giving you the option, I will give you one more picture actually. The patient has smaller lesions elsewhere on the trunk. So you can see the smaller lesions elsewhere. Small lesions, not very clear. I will give you a clearer picture later on. So the MCQ, so one of you, and so few of you think it is pityriasis rosea. So anyone has any other opinion? Nobody has any other opinion? Okay, we'll pityriasis rosea. Okay, pityriasis rosea. Okay, excellent. It's an excellent response. So it's a herald patch of the pityriasis rosea. So it can very closely resemble if the tinea cruris or tinea corporis, because it's more common on the trunk, especially when it appears first. Because at the time when the herald patch comes, there are no other lesions, so that may be the only lesion. So at that time, it can very easily closely resemble a tinea corporis. But it is unlikely to be very much pruritic like in tinea, but that is not a sign that is always reliable, because itching always is subjective. Some people will complain about it more, some people may not tell, so we may not be able to relate. So at that time, it's a diagnostic challenge till they develop the new lesions in a week or so. So when this type of lesions develop later on, it is very easy, isn't it? So I think it is a typical spotter for you with that peripheral colorectal scales and the lesions distributed on the back with that inverted fir tree pattern. So Thrissur Puram again. So we go to the next case. So I think please don't answer now. I will give you a time for that. I'll give you some clues. So you see the lesion very closely. 2 weeks duration, and the rest of the hair is not gone only, it is only shaven only. Okay, only the lesional hair has gone, other thing is shaven off. So options, let me see. Let me go to the poll. Even though I'm getting a few questions. Okay, it has started. I think you can try. 3 people answered. 5. Okay, I think I'm little more satisfied in this. I'm going to close the poll and let me see, share the results. Okay, this is the results that we are getting. So at least some sort of a division is there, even though, but the majority is 15 out of 21 says it is Tinea capitis. But there are few people going for pyoderma and trichotillomania. So we'll stop that. Okay. So as the majority agreed, it is a Tinea capitis and it's a Kerion variety. And I congratulate those who got it on the first attempt itself. And this can be a later stage, it can present like this. It can lead on to a lot of hair loss. And unfortunately, unless you identify it and treat it properly, it can lead on to a permanent hair loss because it can damage the hair follicles. So alopecia areata obviously not, because alopecia areata is non-inflammatory. This lesion that you saw had pustules, inflammation, which was obvious. Pyoderma can be a close differential diagnosis. So it is, but if you find such isolated lesions without any lesions elsewhere, maybe you may be able to differentiate. You have to consider pyoderma. I won't consider that taking that as a possibility is a wrong thing totally. And you have to confirm. Only thing you have to suspect Tinea capitis. And once you suspect it, I think it is easy to confirm because you can take the fungal, the hair clipping can be taken and that will show plenty of fungi. It won't be very difficult in a cavus, simple laboratory. And trichotillomania, obviously, it is not, even though it's a common thing in children. Again, it's not a non-inflamed lesion. And you find a partial hair loss only. You find only some hairs lost in between. So even though some of the dermatological conditions can be little unsightly like this, but there are a lot of very beautiful sights around us. Let us hope we will be able to watch them live soon. It has already started, I believe. So we go to the next case. So look at the lesion. And I again request you not to answer immediately. I will ask you to answer, then you can start answering. That will be better for those people who are not so much of experts, because obviously we have a mixed group here. Those some of who are very experienced also. So please hold on. So look at the lesion. Another view. A little too older than a cradle cap. I will give you some clues. It's the first episode. Lesions are pleural, and there is history of pustules before this. Okay. So I think we'll go for the polls here. Okay, I hope you can participate in the quiz now. Give a few more seconds. 10 seconds, 30 seconds, few more. I think there's a lot of enthusiastic response, so I will keep on the polls for a few more seconds till it is closed. And a rather divided opinion also. So I will end the poll now and let us see the results. Can you see the results? So we have a divided opinion. So psoriasis of the scalp, pyoderma subsiding, seborrheic dermatitis, and Tinea capitis. Actually, if at all okay, we'll discuss them one by one. I think that is better. So I will tell what was the actual case. And again, I am not expecting you to make a correct diagnosis only by that picture. I am presenting this as a picture only to make you participate in that. And only those clues are not probably sufficient. I agree with you. So nobody, please don't feel bad that no, my answer is different from your answer or the other way around. Okay, so it is actually a pyoderma which was subsiding. I think I will go back to it and tell you why. So psoriasis of the scalp is definitely a valid DD, one look. And because there is a patchy area of involvement, that is a typical feature of psoriasis. Scaly lesion involving in discrete areas, sparing other areas. So you are perfectly fine in considering psoriasis. I will also consider. Pyoderma subsiding, why I kept this slide is not to make you feel anything like that, but remember that a pyoderma, subsiding pyoderma can present exactly like this. So before you go to make a diagnosis of psoriasis of the scalp, consider this also, the simple thing which is treatable and which may not produce any trauma to the psyche of the child or the parents when you tell the diagnosis. So simple subsiding pyoderma can look like that. And psoriasis, I have a slide there, so I will show you. Seborrheic dermatitis is probably unlikely because of mainly two reasons. One is rare in that age group. So there is something called an infantile, in quotation, inverted commas, about infantile seborrheic dermatitis. Some people question its actual connection with the other seborrheic dermatitis, but otherwise, it's a disease after puberty and very seldom. But nowadays, puberty is little younger, comes at a lower period. So that is also there, but this child is too young probably for even for that. And secondly, seborrheic dermatitis will have more diffuse scaling, equal, and it won't be so much of scaling is unlikely. The degree of scaling is more, and the involvement is not in all the areas. Tinea capitis has to be considered, it's a DD. So these three are actually valid DDs clinically. You have to consider them and evaluate. Otherwise, then only you can clearly differentiate it. And you can't make assess for diagnosis. So that is why I'm telling you, don't bother about the Qs. That is why I'm not giving you any marks also or prizes also for that. This is only to illustrate some of my learning points. So what I want you to understand from this is that a subsiding pyoderma can resemble psoriasis. So if you have taken up that point, we'll go to the picture of psoriasis. So see what happens here. The psoriasis is essentially a plaque, even on the scalp. You part the hairs and you'll find the plaque actually. It means that erythematous plaques. Whereas our patient, there's nothing like a plaque there. It's only this scaling crust only. And the earlier phase, you find the remnants of the crust here, if you closely examine. So it's a crust scale actually. So the pustule, and I had given you one clue for those people to suggest it could be a pyoderma that I had, that is why to make it a little easier, I told you that there was pustules. So a pustules, history of a pustule subsiding with this type of scaling and some remnant of the crust. Nothing but pyoderma of the scalp, very common. Look for the causes, it could be pediculosis. It could be, sometimes you can get a rapid immediatization on the scalp. So treatable disease. So consider that always before we think about core dermatology, things like that. So this is psoriasis, and psoriasis is another patient, adult patient, just to show you that classical corona psoriatica. And with the onycholysis, typical onycholysis, the distal onycholysis with some pitting there. Okay, spot, which is a place. Okay, this is for the Thrissurians. Please identify, you can unmute one of you and spot the place correctly. Okay. Or Padnyarachara. It's Padnyarachara, what do you say? Anyway, we go to the next case. Symbol. It's a spotter for you. I will give you the clues. 1 month duration, pruritic. Picture once more. 1 month duration, pruritic lesion. So I am going for the QCM. So please don't answer, because the polls can give some interesting results like we have already seen. So it will be launched in a second. Okay, just started. You can try to answer. Okay, 10 seconds more. 27% participated, 30, 31. I think it is going to 50% in 5 seconds. Okay, again, okay, it's not a very bad MCQ because there is a some amount of answer for every question. So share results. Okay. So nearly half tinea facie, seborrheic dermatitis, folliculitis. So I'm not asking who answered, etc. So that is not needed. No, that's one of the advantage in this online quiz. So go to the answer. Okay, so again the majority is right. So I think the majority is always right. So it is a tinea facie, even though it is a adolescent in acne can very easily occur at this age. Folliculitis can be a DD. There are pustules there. Seborrheic dermatitis also is a common lesion, but the discerning eye will be able to see these annular lesions, the well-defined annular lesions. So before we make a diagnosis of acne and start prescribing the anti-acne medicines, have a look at other areas. So what is the easiest way to confirm the diagnosis? I think I will answer to save time. Easiest way to make a diagnosis will be, would anyone unmute and answer that? Easiest way to make a diagnosis. Anyone? Please don't feel
Scratch with a cover slip, something like that. No.
KOH mount.
Magnifying
KOH mount.
lens.
Okay.
KOH
Okay.
mount.
Thank you.
Magnifying lens.
KOH mount.
Thank you, sir. Thank you for your response. The best way to make a diagnosis is look at other typical areas of the patient. So most often these people, this will not be isolated on the face. So it is because of that we are finding it little doubts. This patient will invariably be having lesions elsewhere on the body, typical areas, particularly groin. So I can bet that this person will have a lesion on the groin. So look at that, and your diagnosis of acne and other things are all immediately gone. All of your answers are right, but the first thing that you can do most easily is this one. Hand lens, of course, you can use to find out that pattern more clearly. But look at other areas. That will be my advice as a clinician. Okay. Okay, this is not this patient. And this is also acne. No question here. I will just discuss it and go. These are acneiform lesions. But what is peculiar is that it is limited to this area. So, anyone? Okay, I will answer because otherwise it will take a lot of time. I think your time is precious. This person was applying a topical corticosteroid cream over a lesion here. You can see a hyperpigmented lesion, which was there already. So for what was the diagnosis originally, I can't tell now. But for some whatever purpose, or was it a scar, he was applying the topical corticosteroid over that area for quite some time, for a month, few months, and that will lead on to a steroid-induced acne, localized to that area only. Okay, familiar to you? So now again a familiar case to you. So you can try to look at the lesion. We will go to the questions later. Please don't answer now for the sake of others. So have a good look. And very easy clues actually. I think with this, I expect most of you will answer. Recurrent every year, it's coming, and maybe in a particular season. And it is essentially asymptomatic in the sense that there is no itching or pain. And I will go for that online quiz, which I would think that can be interesting. and or maybe all of you will be able to answer. So I am launching it. So it is open for you. I think I am going to close the poll immediately. Okay. One tinea versicolor came for somewhere, but okay, it is a typical pityriasis alba. You got it correctly. Hansen's disease. Why it is not Hansen's disease? Because it is recurrent. You don't get recurrent Hansen's disease. Otherwise, the lesion can be suspicious of HDI, and the sensory impairment on the face may be unreliable. I not mention whether it is sensory impairment or not. Even if there was no sensory impairment, was there, it can be HD, except for the fact that it is recurrent. So that will not happen. Pityriasis alba typically occurs in the winter season, the dry season. And the post-inflammatory hyperpigmentation, actually pityriasis alba can be considered as a post-inflammatory hyperpigmentation. If you go a little theoretically, this is actually an eczema resulting in the hyperpigmentation that is showing up. And tinea versicolor, perhaps not. Typically the tinea versicolor will have that Circilian border here. It is little well defined, so I will give it to you. It can be recurrent also, but only on the face of that child like that. May not be the, but only one answer for tinea versicolor, which is not entirely wrong. Why I took up this picture is because you see this case. Pityriasis alba, I was expecting that all of you will answer. So I'm not surprised that you all chose that except one. But here what do you find? So I'm not asking you actually this question, but would anyone would like to answer this? Maybe unmute and answer. Anyone, if you feel like only. Essentially, it's like a pityriasis alba only, but some difference is there. Isn't it? You find something in the center. Can you guess what it is? Okay, I will give you the next picture of another patient actually, not this person. Then you will be able to answer. This is another boy, similar site only. Now the diagnosis is obvious, isn't it? So what I wanted to tell you is that molluscum contagiosum sometimes can present in eczematous lesions around it. And it is called Meyerson phenomenon. And it's actually due to the sensitization to the viral antigens, which can happen in some people, we don't know. Not very common, maybe in 5% or less than that, you may find a hyperpigmentation, eczematous reaction subsiding with hyperpigmentation, resembling pityriasis alba, except for that central lesion there, which is probably a subsiding molluscum here. That's why it is looking like that. And it usually once that eczema develops, the lesion in the center will automatically subside also. Molluscum contagiosum. You can't see the picture? Others?
No.
No one? What about others?
We can see it. We can see it. I
Okay,
think,
sir.
yeah,
Sir,
very clear.
It must be your internet problem, sir.
Yeah.
Shall I proceed? Okay. So, okay, we'll go to the next case. See the picture very closely. Questions are coming. Be ready. So longer duration, 6 months duration, minimal pruritus. The person has psychosis or a abnormal psych. So we'll go to the quiz. So please don't answer now. You have the options. Okay, I've launched the quiz now. Dermatophytosis, erythroderma, psoriasis, scabies.
Aye.
Okay, I think we have got responses from a quarter among 27. I don't know how many participants are there in total. Okay, and satisfying result for me in the sense that it is somewhat shared, so that there was a point in keeping that question. So 21% dermatophytosis, 18% erythroderma, 29% psoriasis, and 32% scabies. So rather equally divided. So we'll stop sharing that, and okay, we'll go to the question part. So what was our case? Okay, we'll take them up one by one.
So this is one question which is shared answer equally. So you have to give more detailed answer.
Yeah. I will try. Okay. It's a chronic disease. Okay, what were our options? So dermatophytosis. Okay, see, these lesions are ill-defined. Ill-defined lesion. I don't know whether it will be a little tougher for a pediatrician level to tell that it is ill-defined, but you are finding no involvement here and there, scattered without any clear-cut patches. So, and scaling like this, a lot of crusting. So unless it is secondary infected or eczematized, you won't find these changes. It can occasionally occur. I don't tell that it will not happen, but that absence of those. And dermatophytosis typically will be pruritus, but here we are told it is patient is psychotic also. Now, erythroderma, no, because it is not involving all areas rather equally. So there are a lot of areas which are spared. So that is why we ruled out erythroderma. And minimal pruritus. So our other option was psoriasis. Psoriasis, again, it's not well-defined lesions. So definitely not psoriasis, unless it's a psoriasis which has become eczematized, which is a rare thing which can occur in psoriasis, but not common at all. So why not scabies? What is the point in favor of scabies? One, it not only immunocompromised. Crusted scabies can occur in people who have an abnormal mind, like those who don't really perceive itching. To perceive itching, you need what? You need a proper mind, isn't it? So if that is not there, it can also occur in people who don't perceive the sensation, who have widespread sensory deficit. Also, it can occur. Mentally retarded. All these people are likely to develop. And scabies is highly pruritic, but crusted scabies is minimal. It becomes crusted because it's minimally pruritus. Why minimally pruritus? Because patients don't react normally, either immunocompromised or conditions like what I mentioned already. And it can be chronic. So the patient had crusted scabies, and how do you make a diagnosis? Very simple. Take a scraping and you put under microscope, you find millions of the scabies mite. So this is to give you an insight that, now again I am telling, thinking about psoriasis or is nothing wrong here. Can think about all of them, perfectly fine. But think about scabies also. That is my point. So that is my learning point that I want to tell. No, and my learning point is not to think about psoriasis, but to think about scabies. That is my learning point, because once you think, you will be able to confirm it. So we go to this simple thing. I think I need not even ask you, isn't it? You may be seeing day in and day out. So I think we can even avoid the poll here to save time. 1 week mild fever is MCQ only, not an online poll. So okay, I think I will proceed with that. I think it's too simple for you. Maybe you can, if at all, you can benefit by that picture. So you can get similar lesions in erythema multiforme, which obviously you know. You can get similar annular lesions with central vesicles and pustules in erythema multiforme also. Sometimes in widespread hand, foot, and mouth, and both you can get lesions on the hands and feet. So it can be little tricky sometimes to differentiate. Both you can have a fever, because erythema multiforme can even follow a infection, viral infection, mycoplasma. So it is a DD. That is all what I would tell now. So as I already mentioned, I'm not going to the differential diagnosis and management in today's session, because that is not my purpose here. So we have such areas also in Thrissur district, which we used to visit for various purposes. Unfortunately, visits are few, so these sites are become very good for our eyes nowadays. So we go to the next case. So have a look. This is for your test or poll. I don't remember exactly. Let us see. Have a good look, please. 1 year asymptomatic. Okay, this is for chat box. Can use the chat box and give the answers. A, B, C, D. Hansen's, pityriasis alba, tinea corporis, vitiligo. Okay, great. So everyone has Hansen's. So what do you really need? What other clue which you really needed was sensory impairment. I did not give, because once I tell that, then there is no question of an. And I wanted you to see that color of the lesion. It has got that type of a typical coppery sheen of a tuberculous leprosy, a coppery sheen. And this is the spectrum. Maybe I can ask you about that spectrum rather than what is the type of the disease. And that spectrum is, anyone? Unmute. Suppose it's the only lesion. Okay, then you will answer. So TT is a uniformly well-defined lesion. And you can find some healing in the center. What does it indicate? It indicates very good immunity. So can TT heal completely, spontaneously? Theoretically, some of them can even have, but don't take it like that. Once you make a diagnosis of HD, you have to treat. We don't wait for the theoretical possibility of healing, which may actually happen, but that is not recommended. You have to treat because you don't know. Of course, don't vitiligo because you don't have that color. Pityriasis alba, with this history persistent for 1 year is unlikely, an unusual site. Asymptomatic it can be. Tinea corporis will be pruritic, unless there is some other reason for that. So I think I have discussed the DDs here. How and the vitiligo will be depigmented. Okay, and this is another case, not for, I will explain to you, it's another HD case, and you find what is some known typically as a satellite lesion. A satellite lesion, a smaller lesion in the vicinity of the larger lesion, which indicates it has gone, even though the central lesion is looking rather well defined. This lesion tells that the immunity is not that great. So there is a tendency for dissemination. That means there is a go to the borderline spectrum. It's a BT spectrum. Clinically, you may have to correlate with the bacteriology, histopathology, but clinically it's a BT. Okay, identify the place. Either chat box or unmute. Thrissur district only. View from the road. I did not call up Purushottam sir because I knew you. Okay, thank you. Understand. Okay, we go to this case now. I think you will answer without clues. 1 month duration, sudden onset, no pain, no itching. Okay, I think we will skip the quiz here. Isn't it too simple? Can give the options in the. Okay. We'll discuss why it is not. Okay. Why it is not the other types. So other type are appreciated. DLE, it will be inflamed lesion, erythematous lesion, can go for scarring usually, can be little more to attain this size, it will be a little more, it will take a longer time to develop, it's a more chronic to develop. Tinea capitis, of course, will be pruritic, scaly, inflamed, and trichotillomania, even if it is in a child, you don't find complete loss of hair within that lesion. Find only partial hair loss on the sides of the hair. So I wanted to show you this picture. That's why I kept that question. And what is this here? This is the regrowing hairs. So see this person. This person is a middle-aged person. So maybe 40 years, 45 years, like some of us, and has 50% of gray hair and 50% black hairs. And what happens is that when the alopecia areata develops, it preferentially affects the black hairs due to some not 100% explained reason. It prefers the fully pigmented hairs. So the gray hairs will be left behind and the other will go. So you'll find patches where you get only gray hairs. So suppose this person has an alopecia totalis. What will be the picture? Will person like a 50% gray hair, 50% black hair, and alopecia totalis. And same phenomenon happening will lead on to overnight graying of the hair. So somebody presenting like that, overnight graying of, because then more than the loss of hair, these people may complain about that graying of hair. So you may find a presentation like that. Okay, I think we are coming to the last few slides. Shall we take 10 minutes more or stop here? Maybe 2 or 3 slides. 2 or 3 or 2 cases perhaps.
Yeah, 2 cases okay. Sure.
Okay.
We have to take some questions also. Simple one. Huh? Long duration, persistent. So MCQ, you can go for that chat box. Okay, nevus sebaceous is not in the option. B is the epidermal nevus, seborrheic keratosis is the epidermal nevus viral wart. Okay, long duration. Long duration is favoring an evoid condition. All these ones can be persistent. I agree. Acrocodon usually will not be so much lobulate, what is a warty as well as pigmented, even though some pigmentation can occur, but usually it's a skin colored lesion. Here it is a pigmented lesion. And you find a linearity, which is rare to find in acrocodon. Seborrheic keratosis can look exactly like this. It can be seborrheic keratosis, but again, that linear lesions is unlikely. And the lesions will be a little more dry-like lesions rather than so much fleshy. This will be a little more softer lesion in epidermal nevus. Seborrheic keratosis will be more rough actually and a little more drier lesion. And viral wart is it won't persist for such a long time. I mentioned long duration and persistent, and it won't be so much pigmented also. So these are a little more fleshy than the seborrheic keratosis. Individual lesion can look like seborrheic keratosis, but that linearity and close thing again, linear, the lines can be broken in epidermal nevus. It may not be a continuous line, it can be broken lines. So this is what you get in wart. So a patient with extensive warts will be more rough, may not be so much pigmented either. Okay, so our beaches. Okay, okay, this I think I will go for a poll. So you can see the case closely. Last but one case. Please don't answer. 6 months pruritic. 6 months. You can see the site, of course. 6 months duration. Maybe a child who is 12 years, I don't remember the age exactly. Maybe you take as a 12 or 13-year-old child. 6 months pruritic. And our Qs, I think I will open because it could be interesting. Okay, Qs 9. Okay, it has started. A fixed drug eruption, lichen planus, lichen simplex chronicus, post-inflammatory hypermelanosis, hyperpigmentation. So you can go to the polls. Are you able to hold it? I think I'm not getting any answers. Hello? Is it not coming?
It's not coming.
Not coming?
Not coming.
Okay, I don't know what happened. Okay, please bear with me. I will.
We are getting answers, but your polling is not coming.
Okay, we will go with that. So we'll about that poll, we will go to the answers. So C is the most common answer I think I am getting, isn't it? So of course it is C only.
Nice, no?
Can you see and hear me?
Yeah, sure. Carry on.
Okay. It is fixed FDE, lichen planus, lichen simplex chronicus, and post-inflammatory. So there can be a little bit of confusion. Fixed eruption can present like a pigmented lesion, can be circular like that. But here you can find it a little more verrucous and more, isn't it? And but a healed FDE can look like this and can be persistent till the drug is taken again. So it may not be totally wrong. So I would have expected some people to tell fixed drug eruption also. Lichen planus, not, because it is not that well defined. And see, the entire lesion is rather ill defined. So we are actually finding lichenification. You can see that prominence of the, rather than flat top papules, what you are finding is the prominence of the skin creases. That is what you are seeing here. So that is a feature of lichenification, not in lichen planus. Lichen planus does not have lichenification. Even the lichen is there in the term. Lichenification is a feature of lichen simplex chronicus or neurodermatitis. So some of you have already answered. And it cannot be only be a post-inflammatory hypermenosis because the lesions are.
Can I take a photograph of it? What?
Okay.
Then take a better print screen or some different screen. But print screen or something.
Can I think some voice is coming? Okay. So okay. So this is actually meant to show you what is a fixed drug eruption. But this erythema will come only when the drug is taken again, only in the acute stage only. And after that, it subsides. It can go back to that hyperpigmentation. So at that stage, it can occur only that like that hyperpigmentation in the previous patient. Okay. So I think I will skip this. I think this all of you know. Persistent lesion, pruritic systems are normal. So urticaria pigmentosa. I will show you this typical diarrhea site where you find the dermographism. You try for the dermographism. You find it more prominent in the lesion compared to the periphery. Even though a little bit of dermographism can occur on the apparently normal looking skin also. That doesn't rule it out. But wheals which is more in the lesion compared to the periphery. That's only what I this is the last case. I think I will show you because I wanted you to appreciate this. So 2 or 3 pictures you can see. Can you see the pictures? Last case. Okay, 2 years. There are recurrent skin lesion and they subside with hyperpigmentation. Okay, this I am trying again. Last time I don't know what happened. The Qs did not happen. So Qs 9 all ended. Okay, just 1 minute because I want him to try this if possible, if it comes. So I have launched it. Are you able to get? Are you able to see the cues? Okay, yeah, thank you. I think I'm getting the responses. Okay, I will end the poll now. I have got enough options. So 35% divided, 35% cutaneous alba, post-inflammatory, and tinea versicolor. Okay, so go to the answer. Okay, it's post-inflammatory hypopigmentation. Okay, I think it's a typo. It's a hypopigmentation. Post-inflammatory hypopigmentation. I mentioned pigmentation. Okay, sorry for that mistake. I have already mentioned hypopigmentation in the finding. I meant post-inflammatory hyperpigmentation only. And why? Because the lesions are, it's not only hyperpigmentation. There are lesions. So the thing is that everyone will be concerned about, including us, will be concerned about the hyperpigmentation. Parents will all will complain that the child is having hyperpigmented lesions. Because the skin lesions are not that prominent. They last only for a few days and subside. But there are lesions. If you look carefully, you find erythematous or slightly violaceous lesions there, which subside with hyperpigmentation persists for a longer period. Okay, so it is post-inflammatory because this is because following the subsidence. And I wanted you to be aware about this entity. This is pityriasis lichenoides chronica. It is not as marked or florid like psoriasis. Gutted psoriasis is the closest differential diagnosis, but there the skin lesions will persist for a longer period. There will be more erythematous. They remain for a longer period. Even though gutted psoriasis can subside in weeks, but here the pigmentation will be more marked here, usually in the pityriasis lichenoides chronica, because lesions will come only a few at a time, but the pigmentation will take months to subside. By that time, new lesion will come. So the complaint of the patient will be more that of a persistent hyperpigmentation, where in fact lesions are actually coming and going. And this is of course you don't get such papular lesions. So many lesions are uncommon, trunk lesions more again. So that's why pityriasis alba is unlikely. Tinea versicolor again won't have that papular element, and the history also is not like that. I have given you that history. Vitiligo, of course, no papules, only depigmentation. So I think നമുക്ക് ഒരു ഉപചാരം ചൊല്ലി പിരിയാം. So I think I thank once again for your wonderful cooperation. So if there are any pressing questions, I think we can discuss anything, or you can share your opinions. I think I would also like to learn from you. Some of you can share your experience rather than ask me questions. And
Ashwagan, can you stop sharing the screen?
Yeah, can I?
So thank you, Dr. Ashwagan, for the wonderful journey. The entire session was very alive, and many veterans, very senior leaders also shown that they are all expert in the quiz program, because they are not getting a chance nowadays. Only youngers are getting, so you go to more answers. We had around 89 participants, 25% of them actively involved in quiz program also. And it was a wonderful presentation, and different types of presentation, and everybody enjoyed it. Dr. Ashwagan, there's one or two questions from my side. One is that you shown an extensive scabies lesion in a psychologically abnormal patient. So how will you treat that one? Second question is that nowadays we are not seeing Hansen disease very commonly, because it may be coming to dermatologist, but we are not seeing. I don't know, Purushottam sir is seeing it or not. Anyway, we are not seeing it. So what is your experience with the Hansen disease nowadays?
Okay, I will start with that second question first.
And another important aspect, Ashwagan, we have many classmates from our side, our 26th batch GMC. There are so many students, as there are so many classmates joined the session. I will meet them later. Okay, now we continue.
Okay, I can see the face of Ramushan already. Anyway, hello. Okay, the Hansen disease overall, not only in children, overall its prevalence is coming down all over India, all over world also. Of course, in India and Kerala also in particular. So we actually in a number of cases, total number of cases per year in a district, in Thrissur district is again maybe 80 to 100. So last year due to COVID, there was again more difficulty to pick up. So actual number has come down, but not a real actual number coming down. Many reasons they are not picked up probably. The household surveys are not that active. But we get a share of them in children also. It's not that the children are exempted from that. So we should be aware about that in children also. And in children, it has to be more important because they have a long life ahead of them. So to pick them up early and start treatment is very important. So it is not a time yet, and it is not a time for us to lower our guard against the presence of Hansen disease in children. So that is my advice regarding that. Regarding your first question, you may treat the crusted scabies in different ways. Yeah. One, because of the thick crust and scaling, first you may have to remove them. So for that, keratolytic applications may be needed, prior treatment, before you start giving the anti-scabitic topicals. So you may use Colta just like you do in psoriasis. So you may have to do that prior treatment and then give the topical antiscabitic agent. And the topical antiscabitic agents will have to be done repeatedly. Unlike usually we say permethrin only one application, but here one application is not going to be enough. You may have to apply daily for a period of maybe up to 1 week, depending upon the response. But usually once you start treating them, it will respond, because it's not a question of the mites not responding to the antiscabitic agent. It's the only thing that they are not recognizing it. So whether it is 10 mites or 1,000 mites or 1 lakh mites, everything will be dead once you ensure that the drug reaches there. So it can be treated very efficiently. And another drug that we use in the custard scabies sometimes, for practical convenience also, you can use ivermectin, or you can supplement the topical. So these are the different modifications that we make in the treatment of custard scabies compared to typical scabies. Any other question you asked?
One question is how to treat chronic tinea crodis not responding to azoles.
Okay, refer to your enemy doctor. That is the best way now. Told in a lighter way. Thing is that whoever treats the tinea is now refusing to respond. Whether it's treated by a pediatrician or dermatologist or resident or professor, the tinea has changed its behavior, and it has been a big treachery on us, because it was one disease where we were confident that we can completely remove. Earlier people used to ask us, you dermatologists make all diagnosis, but you don't cure. But then we used to answer, no, we are curing all these tinnias and scabies and everything. But the tinea has gone out of our bag now. It's very difficult to treat. And some of the options are the fluconazole response is very poor in various studies. So more reliable systemic drug is one thing. You may have to go for systemic therapy more often than we used to do earlier. And itraconazole is the drug which is giving more consistent results. But even then, it's not 100% satisfactory. Then you have to be very, very, religious in removing all other sources or causes of chronic dermatophytosis, like another source in the family, you treat them also. The fomites, the clothes, all these were important even earlier also. But now, unless we insist on each and every one of them, it won't respond. Even if we insist, they don't respond, some of them. So I think I have answered you the difficulties, but I have also highlighted the importance of looking at the other factors which may be leading onto the chronicity, the more likely need for systemic agent, and possible better option of itraconazole. I think that is all what I can answer.
Now, I invited Dr. Newton Lewis, senior pediatrician from Pota, to give expert comments, some suggestions. Newton, sir.
I actually have nothing particular to say. I have enjoyed the session. It's a very different type of presentation, and I found it very interesting. Unfortunately, my computer was not working, so I couldn't do it from my mobile, so I couldn't take active part in the quiz. But it was a very enjoyable presentation, and I learned quite a bit from it. Thank you.
Now we have a guest from Bangalore, Dr. Nancy Austin. Nancy, any comments, Nancy?
Nice to see both the batchmates together. Yeah.
Okay.
First time seeing Ashokan presenting, so it's nice. It's interesting also.
I hope I did not disappoint you. Can we see your face?
Oh, sorry, I didn't know. I just, yeah.
Pushon sir orkunundavaayirikam. Pushon sir is our teacher at that time, Nancy. Do you remember me? Pushon sir? Over to Pushon sir, some comments and...
Nancy, ഞാൻ ഒരു ഫിസിയോളജിയിൽ ട്യൂട്ടർ ആയിരുന്നു ആ സമയത്ത്, നിങ്ങളൊക്കെയുള്ള സമയത്ത്. കാലിക്കറ്റ് ഓർമ്മയുണ്ടോന്ന് അറിയില്ല.
സോറി, മാരോളി സാബിനെ മാത്രമേ ഓർമ്മയുള്ളൂ.
Marcos, Pushon sir. Yeah.
Sir was the, at the other pole of Maroli sir. He used to terrorize. And Purushottam sir was a nice face at that.
Any doubts, comments, suggestions?
Ashwin, I missed the initial part because I was traveling from Thrissur to Malappuram. On the way, that is a really, as Dr. Newton sir said, it was a very enjoyable session. I attended a few of them and I made also. And my memories about the Norwegian scabies, that was during that period, 70s, late 70s, we had a posting in Kudiravatam. Kudiravattത്ത് ഇങ്ങനെ ഒരു ടെമ്പോ വാനിൽ ഞങ്ങൾ പോവായിരുന്നു. അപ്പോൾ 1-2 തവണ പോസ്റ്റിംഗ് ഉണ്ടാവും. അതൊക്കെ ഇനീഷ്യലി ഒക്കെ നമുക്ക് വലിയൊരു തമാശ പോലെയാവുമായിരുന്നു. പിന്നെ കുട്ടികൾ ഇവരുടെ കാര്യങ്ങളൊക്കെ വന്ന് നമ്മളൊക്കെ ഒന്ന് തൊട്ടോട്ടെ എന്നൊക്കെ പറഞ്ഞ് ചോദിക്കുമായിരുന്നു. പിന്നീട് രണ്ടാമത്തെ പോക്കിനാണ് അവരുടെ കാര്യം പത്തറ്റിക് സിറ്റുവേഷൻ മനസ്സിലാവുന്നത്. അപ്പൊ അത് ആ ഒരു ഓർമ്മ അന്നത്തെ ഒരു വിധത്തിൽ എടുക്കുന്ന ഒരാളുടെ ഈ നോർവീജിയൻ സ്കാബീസിന്റെ ഓർമ്മ. അപ്പൊ പ്രഭാകരൻ സാറായിരുന്നു അന്ന് സൈക്യാട്രിന്റെ അന്നത്തെ ഹെഡ് ഉണ്ടായിരുന്നത്. സാർ പറഞ്ഞ ഇതാണ് കാര്യം, ഇങ്ങനത്തെ കേസുകൾ ഒന്നും ചെയ്യാൻ പറ്റില്ല. ഇപ്പൊ ഐ തിങ്ക് നോർവീജിയൻസ് ഐവർമെക്റ്റിൻ വിൽ വർക്ക് അല്ലേ?
Ivermectin will work.
പിന്നെ എനിക്ക് ചെറിയൊരു ഡൗട്ട് ഉള്ള കാര്യം, following these post-COVID situations, do you get any new type of dermatological problems due to COVID on one side? Other thing, of course, the immunomodulators may be giving a chance of a newer and newer resistant fungus or and the spectrum of problems, is it changing over time?
Not much, sir. We are not finding much of a post-COVID things. It's not that common in our experience.
കാണുന്നുണ്ടോ കൂടുതൽ കേസസ് കോവിഡ് കഴിഞ്ഞിട്ട്?
അർട്ടിക്കേറിയ കൂടുതൽ കഴിഞ്ഞിട്ട് ഉള്ളതിനേക്കാൾ കൂടുതൽ ചിലപ്പോൾ ആക്റ്റീവ് കേസസിൽ അർട്ടിക്കേറിയൽ പ്രസന്റേഷൻ കുറച്ച് കൂടുതൽ
Any other comments from?
Vasculitis ഉണ്ട് റയർലി, പക്ഷെ അതൊന്നും അത്ര കോമൺ അല്ല, പറയണ പോലെ അത്ര കോമൺ ഒന്നുമല്ല. They say about the erythematous lesions on the fingertips and other things. These are not at all common in our practice.
ഞാൻ 2-3 കേസ് കണ്ടു കോവിഡ് കഴിഞ്ഞിട്ട് അർട്ടിക്കേറിയ വന്നത്.
Any other comments from seniors? Parvati madam. So, madam, Parvati madam. Madam, നെന്മാറയോ അല്ലേ? അതാണ് മനസ്സിലായി.
നെന്മാറയാണ്
മാഡം ടോപ്പ് സ്കോറർ മേഡം കേട്ടോ.
പിന്നെ എന്റെ ഭഗവാനെ, ഞാൻ ഒരെണ്ണം തെറ്റിച്ചു. എനിക്ക് അത് ഐ തോട്ട് ദാറ്റ് ഇറ്റ് ഈസ് സെബോറിക് ഡെർമറ്റൈറ്റിസ് ഓൺലി, ജസ്റ്റ് ലൈക്ക് റെഡിൽ ക്യാപ്.
ഒരെണ്ണം തെറ്റിച്ച് ഇത്ര കുഴപ്പമാണ് മാഡം. ഞങ്ങളെ പുരുഷോത്തമ സാറൊക്കെ എത്ര തെറ്റിച്ചു.
ആക്ച്വലി ഞാനത് അങ്ങനെ ഒരു ഇതിലല്ല, വെച്ചാല് ഐ വാണ്ടഡ് ടു മേക്ക് സം ലേണിംഗ് പോയിന്റ്സ്. അപ്പൊ അത് ഇത് കാണിച്ചിട്ടല്ലേ പറ്റുള്ളൂ. All the questions were not very fair to the contestants because I give only some information, partial information like that. So I am not actually expecting whether you will be able to answer full or anything. But some there are situations where we can have some doubts or dilemmas. So I wanted to bring up those dilemmas through the discussion.
Anyway, it was a nice type of presentation and we learned quite a lot.
It was a style of presentation was out of necessity because that was what I could do in 4 days. I had a really tough time even otherwise. A lot of activities are going on. So this was my main difficulty was to get all these slides from my storage. I took leave for 1 day and collected all these slides which I thought I can share with you. That is the main job.
Yes.
And ഒരു ചെറിയൊരു സജഷൻ എന്താണെന്ന് വെച്ചാല് actually there are cases of leprosy in pediatric age group, but the present generation of pediatricians and postgraduates are not seeing them because there is a very good system before the COVID. There's a very good system of screening and directly they are going to the dermatologists. And I have got some interest, I'm taking some interest and good relation with Ashokan and Ajay Ghosh was very smart person. He retired recently from dermatology. So I know the actual numbers over the state and what the status of Thrissur and all. But there are cases and different types also. We pediatricians are not aware. I think Ashokan or other dermatology surveys and talks will be included more frequently in statewide presentations. That pediatric dermatology in the include especially leprosy.
I think that is a very wonderful session. Even after 1 hour 30 minutes, still audience are very active and actively participating. My personal behalf, I thank you, Dr. Ashwakam, for the beautiful slide and beautiful quiz program. For official vote of thanks, I invited Dr. Srijit. Dr. Srijit.
Thank you, sir. Thank you, sir. We are caught in between organizing a physical program of monthly meeting and organizing a Zoom program. So that's why we can arrange this program only lately. So we are very thankful for Ashokan sir to accepting our notice and presenting this wonderful slides and the wonderful quiz. And we are all thoroughly enjoyed your talk from start to the beginning, and very good learning experience for all of you who joined us. So thank you once again for Ashokan sir, and also thank Anandeshan sir, Riddhi madam, and all the senior Purushottam sir, Parvati madam, Newton Lewis sir, and Devendra Masar and Saroja madam, and all the senior members who had joined for this monthly program. I hope you to join the next program or on Thrissur Talk series as usual last Thursday. So hope to see you on that day. So we will call it a day, and thank you and good night and yay.
Okay, thank all of you for your wonderful participation. And you are very patient. Thank you.
നല്ല attendance ആയിരുന്നു, very good attendance.
അത് പറയാൻ
കുറെ പിന്നെ ബാലകൃഷ്ണൻ ഉണ്ടായി കേട്ടോ അശോകൻ.